what is supposed to be up. Hello and welcome everyone to our fifth and final session of our webinar series on partnerships for resilient health systems, brought to you by Africa Health Business. My name is Maggie Kiplagat and I am the head of operations at AHB. Before we start the discussion on human resources for health, I'd like to take you through some housekeeping rules. Attendees will be on mute during the session. This is a 90-minute event. Please note that you can post your questions in a Q&A section on your screen, and your questions will be responded to as much as possible. Throughout the webinar, there will be pop-up questions, and we encourage you to respond. The results of the questions will be shared with you towards the end of the webinar. I would like to take this opportunity to introduce Africa Health Business. We are a Pan-African boutique consultancy and advisory firm based in Nairobi, Kenya, that aims to improve access to equitable health in Africa. Through a private sector lens, we provide organizations with actionable insights to grow their health agenda in Africa. On this slide, you'll see the agenda for today. I would like to reiterate that this is a 90-minute session. But before we dive into today's discussion, here's a short clip on one of our event sponsors, the Medtronic Foundation.
Medtronic Labs is built upon 5 principles. First, we design with and for the communities to address local barriers across the care continuum. Second, we employ evidence-based practices and protocols for uncompromised clinical excellence. Third, we address the social determinants at the root of poor health. Fourth, we integrate digital and product technologies for high-tech, high-touch models of care. Fifth, we innovate operational models that enable efficiency at scale. Learn more at www.medtronic.com/Medtronic.
Thank you, Medtronic Foundation. So I am very delighted to be with you here today to have this discussion around the state of our healthcare workforce. As we all know, the world continues to face a shortage of healthcare workers. WHO reports that the world will be short of 12.9 million healthcare workers by 2035 if the shortage issue is not addressed now. Available statistics show that over 40% of WHO member states report to have less than 10 medical doctors per 10,000 population. Over 26% report to have less than 3 medical doctors. Healthcare workers are distributed unevenly across the globe. Countries with the lowest relative need have the highest number of health workers, while those with the greatest burden of disease have much smaller workforce. The African region suffers more than 22% of the global burden of disease, but has access to only 3% of the healthcare workers and less than 1% of the world's financial resources. I know we have a shared interest in this topic, and we are happy to have this opportunity to have this discussion with you all. And so without further ado, I would like to welcome Dr. Kate Tolenko to take us through the discussion. Over to you, Kate.
Great. Thank you so much for the introduction. So I'm Dr. Kate Tolenko, and I'm a health workforce specialist physician, and I'm the founder of Corbis Health. And it's a pleasure to be here today. As all of you know, COVID-19 has highlighted the shortage and maldistribution of health workers globally, as well as in Africa. Africa has 24% of the global burden of disease, but is home to only 3% of the global health workforce. The shortage of health workers not only affects health, but it affects GPD, it affects economic growth. There's been very important work done by Edson Arauja and Akiko Maeda at the World Bank to show that governments that invest more in health workers and training health workers have faster economic growth, even when corrected for the wealth of the country. And although quality and productivity initiatives are needed, the greatest need is to train additional health workers in direct relationship to the demand within the public and the private sector. And with the ending of large-scale MEPI and NEPI initiatives, there really is no global or regional initiative to expand the pre-service education of healthcare. But fortunately, the private sector is uniquely positioned to help the public sector act strongly and create more healthcare workers. The private sector can catalyze the expansion of existing schools, as well as found new schools. I think that one misconception that there is that it has to either be private schools or not private schools, but there's a possibility of partnership with public schools, with private providers providing online curriculum or providing school management, or providing access to private clinical rotations for healthcare workers. For example, one step is to address the shortage of instructors and reduce the cost of operating schools. There are some efforts globally. For example, Nurses International is working on putting a full curriculum for nurses online that would be free and available to all. And within the medical schools, there's a regional initiative in Europe put on by EDU to have an online medical school, as well as Medicist working globally. We also need to improve the financing of health worker education. Afya Limu in Kenya was set up as a revolving educational loan system that has enabled thousands of students to study who otherwise wouldn't have been able to. And the private sector has bought into this, and you even see private hospitals who are funding health workers who then agree to work with them for an agreed upon period of time. So with that framing of sort of the power of the private sector to work with the public sector and expand more healthcare workers, I'd like to introduce our keynote speaker, Dr. Elizabeth Walla. So Dr. Elizabeth Walla is Global Advisor, Health and Nutrition at the Aga Khan Foundation. She's a health programs manager with over 15 years experience in programs design, management, and implementation. She has served as a key contributor to the development of several guidelines, health bills, and health policies. She's an accomplished leader, known and respected for program refinements and building credibility and partnerships with leading national and international health sector stakeholders and non-governmental organizations, including ministries of health, county governments, the World Health Organization, the IFC and the World Bank, IntraHealth, UNFPA, and Gavi. In her role at the Aga Khan Foundation, Dr. Walla works in close collaboration with their Health and Nutrition Global Lead, alongside with members of the Foundation's Global Programs team to support the promotion and implementation of the Aga Khan's health and nutrition strategy. Dr. Walla will speak on health worker resilience.
Thank you. Thank you very much, Kate, and hello to everyone from wherever you're listening from. I want to just, first of all, pause and reflect on health workers. First of all, here is to you with deep thanks for all the health workers fighting COVID-19 at the front lines of healthcare systems in Africa and across the globe, putting their own health and safety at risk, and for the numerous health workers who have lost their lives during this pandemic. So at the beginning of this year, there were just very few people in Africa who are concerned about the outbreak of the new coronavirus and aware of its global consequences. A few months later, when COVID-19 has spread across the globe and caused the most serious pandemic of the last century, the world has changed. So protecting health and saving lives temporarily dominated politics and disrupted everyday life and routines. This pandemic has shaken and triggered policy developments that public health professionals have been advocating for many years, that the health workforce was moving from cost factors and faceless numbers or units of health producers to the heart and soul of the health system. When the pandemic, if you remember very well, was peaking in Europe, We had quite a number of people applauding health workers. Every evening, there were banners in public places who were expressing appreciation for frontline personnel. Business companies, sports and film stars, and many others were standing and donating for health workers and better personnel protective equipment. But has that been the case in Africa? So countries under lockdown have discovered that healthcare workers as their new heroes. There's a welcome sign of appreciation of frontline healthcare staff, but it is neither sufficient nor sustainable. We do not need heroes who pay for their life with their health and well-being, even with their life. What is needed is that the most healthcare systems that take care of the health and well-being of their staff, and societies who are willing to pay them in a fair and gender equitable manner. So during this pandemic, we've seen the impact of overburdened health systems pushed to the limits, and Africa has not been spared of that. And the heart of those systems are our health and other essential health workers who have risen to the occasion with remarkable expertise and determination despite enormous risks. But that determination clearly comes at a cost and begs the question, how can we better care for those who are caring for us? And there's a lot to learn for health systems and the health workforce from country responses to this crisis. Some of the major issues that we've seen coming out is one, the health workforce surge capacity through mobilizing health workers, for example, those who are retired or those who are unemployed. Number two, we've seen introducing rapid upskilling and skill mix changes according to local needs. So we've seen the pandemic has actually required from the most basic of community health workers to the specialists who are involved in critical care. Number three is that we need to protect the physical and mental health of frontline health workers. We know that health workers are human beings like everyone else. So them being on the front line not only exposes their mental health and well-being, but also their lives. Number four, how do we compensate income loss for health workers? And number five, for those who are operating nursing homes, where we've seen the pandemic moving into, and health workers in that case, we have not dealt with that. So for most of these issues, we can only hope that the lessons learned will be retained after the pandemic. We also need a very strong political commitment to and support for African workforce governance that ensures solidarity between countries. How can we do this? I have, and I'm recommending a three-pronged strategy for this. Number one, first, we have to ensure that we prioritize the safety of health workers during the pandemic response. This includes personal protective equipment, donations, training, technology, and other immediate support for communities. The second thing that we must address is providing mental health and psychosocial support for our health workers who are on the forefront of fighting this pandemic. They're struggling with even greater pressures on their resilience and well-being. Finally, but not least, is we have to work together collaboratively, from governments to ministries of health to stakeholders and that's why this platform is very important. Around the world, we have to put in national action plans for pandemic response and health system strengthening. It cannot be business as usual, and we cannot get out of this pandemic without lessons learned. So while much has been appending during this time, we should be committed to building resilient, community-based health systems with thriving frontline health workers at the heart of it. COVID-19, like what most disasters tend to do, has yet again brought to the light the glaring inequities in our health system that puts out our most vulnerable communities at risk. So approaching our response to this within the larger context of driving systemic changes in our community health systems, we need to focus on the health workforce. This will allow us to meet the needs of the moment while maintaining progress on critical objectives for the long term, and we should never stop. Thank you very much, Kate. Over to you.
Thank you, Dr. Walla. Really appreciate that. So our next speaker, actually, we now start our panelists. We have 5 panelists who will each speak on a topic in health workforce. It looks like we have our first question for everyone. So the question is, what are the biggest challenges to human resources in Africa's healthcare sector? So just click the radio dial of which you think is the biggest challenge, and we'll give you the results at the end of the session of what everybody in the audience thought. So just click that and then we'll continue. So our first panelist is Frank Waffler, who's General Manager, Roche, East Africa. Frank joined Roche in 2001 and has held various commercial positions in pricing and key account management in Roche, Germany. In 2013, he joined the audit team in Roche headquarters in Basel, Switzerland, and afterwards served as Regional Compliance Officer for Eastern Europe, Middle East, and Africa. In 2006, he moved with his family to Addis Ababa and opened up the Roche Commercial Presentation Office in Ethiopia. Since February 2018, Frank has been working with Roche Kenya in Nairobi, and in his current role, he oversees the Roche business in 10 countries in East Africa, starting from Sudan in the north and reaching all the way down to Tanzania in the south. Frank will be presenting on several topics, including education of healthcare workers in public-private partnership and the skill needs that the private sector has. Please, Frank.
Great, thank you so much, and a very warm welcome and good afternoon also from my side to everyone listening to us. Thank you also very much to HBS for inviting me and setting up this very valuable talks over the last days. I would like to start with something which is very close to me, because also I'm managing a business. So also for us, we have a need for human resources. And I must admit, working for the industry, there is a kind of a competition between us and the healthcare sector treating the patients, because also we are looking for medical doctors, we are looking for pharmacists, so we are looking for nurses working for us. I still believe that this is very important, because for me as a business leader, it is very clear any employee of Roche interacting with a healthcare professional providing service to the patient has to be educated and has to have a skill-based training which allows him to work on an eye-to-eye level and really to speak the language of the healthcare professionals in the market. So I think this is very important to recognize that also then the quality of the work we can do as industry, not only pharmaceutical, or also diagnostic industry or medical device industry, is really also depending on the very well-trained healthcare workers, which we need to have also in our teams. The second point I would like to raise is then a point to say technology and innovation can help us to save resources in the healthcare sector. So for example, there are virtual ways of connecting healthcare professionals. We have technologies which allow, for example, to do digital pathology, which means the pathologist judging on a certain result can sit in any place in the world to do his work and feedback then the report to the patient. Even more so, we also have to think in innovation can be another efficiency gain. So for example, there are innovations that you go from an IV product to a subcutaneous product. So you don't need to have a patient in a healthcare institution for 3 or 4 hours to receive infusion, for example, with a monoclonal antibody during cancer therapy, but you can administer the same thing within a few minutes through a subcutaneous injection, potentially also in a home-based care on the long run. Also, this will help. And on top of it, of course, you also have innovations which allow you for longer therapy cycles, which also can come with a big benefit and take out the workload for the limited healthcare professionals we have. And now to my last point, it's education. And I believe strongly in education that also we as an industry play a very big role. We have to engage in private partnerships or in public-private partnerships and make education part of the service we deliver. It is not good enough that we only come with products to the markets. We must be able to help to develop an ecosystem which ensures that the products we produce, the products we innovate are really reaching the patient, and then there's trained healthcare workers providing the due care to them. So I would almost say, stealing on a quote which was made on Saturday in the vaccine session, it's not an innovative product from the industry which is saving lives. It's the ecosystem of healthcare professionals providing it to the patients which will save the life. And there I can just mention only this year, 2020, in partnership with the International Cancer Institute in Eldoret, Roche was able to train 370 surgical preceptorships for oncologists from 7 countries across Africa. So we did it online and we also did it offline and in face-to-face sessions, depending on the pandemic situation. And all of these trained people are deployed mainly outside the capitals and the big cities in more smaller towns, and here in Kenya, mainly in the different level 5 referral hospitals in the county. So within 12 months, through a strong public-private partnership involving the Council of Governors, involving the International Cancer Institute, and involving us, we could build up 7 treatment and screening centers for cancer across Kenya alone, and impact many more places in other countries, as I mentioned before. Now, to close with, I just would like to also mention that I do not see yet within the procurement decisions in private sector, but also procurement decision in public sector health care institutions, that the whole engagement of a supplier in terms of the ecosystem is always recognized. And I think this is a very important part, that we also realize we cannot, let's say, select the suppliers on the one hand, maybe based on a pure price comparison, and on the other hand, then are disappointed that there is no engagement from the industry part for education. So it really there needs to be competition, there need to be fair prices, but there also needs to be a recognition of value which is delivered by a supplier or by the industry into the healthcare sector. With this, I would like to stop. Thank you so much for this. I'm very happy then to discuss with my dear panelists and all the audience through the Q&A session further on these points. Thank you so much.
Frank, thank you so much for your presentation. I found it especially interesting what you were saying about how makers of pharmaceuticals and other medical products need to think about the relationship between their product and the health workforce. For example, if a drug is IV, it would need to be administered by a RN, whereas if it's perhaps subcutaneous, it could be administered by a community health worker or other type of purpose-trained health worker that could be more available, particularly at the community level. I think another important issue regarding the health worker in the private sector is that when most countries plan their health workforce, what types of workers they have, how many they'll train, they only look at the needs in the public sector. They're not looking at the whole of the market. They're not looking at what the private sector needs as far as type of workers, the skills, and the number of workers. And what you often see is the public sector trains enough workers to meet its needs, but then they, of course, just get hired away by the private sector. So governments really need to plan a whole of labor market approach as far as educating and managing health workers. So our next speaker is Dr. Agassi Dagud, who's president of the Tunisian Health Alliance. Oh, now I see we have another one of our questions pop up. So the question is, what factors would improve health service delivery in Africa? So answer the questions and we'll see the results at the end. So Dr. Dagud holds an MBA from Henley Business School and started his career in the health sector in 2012 by joining the Amen Sante Group as Director of Development. At the end of 2014, he launched the Institut de Métiers de Santé, IMS, a continuing education institute specialized in using medical simulation technology to train health professionals. Dr. Dagud was appointed president of the Tunisia Health Alliance in September 2019. And Dr. Dagud will speak on health workforce education and training.
Thank you, Kate. Good morning, good afternoon, and good evening, everyone, wherever you are. First of all, I would like to join everyone and thank all the team of AHB, and in particular Kosha, for giving me the opportunity to participate in this webinar as a panelist. I also wish to pay a heartfelt tribute for our caregivers who were at the front lines doing a huge job to save lives during this deadly pandemic. Of course, this COVID-19 has put under pressure the health system all over the world in different ways. Several challenges have been raised by the availability of the caregivers have been tremendous. Indeed, and as it was said before, most of the countries suffer from this shortage, a shortage of healthcare workers, even before the pandemic crisis. The World Health Organization estimates today a shortage of 17 million health workers globally. Of course, this is a big problem facing different health systems. And unfortunately, the African region had the most severe one, estimated to reach 6 million by 2030. With the COVID-19, the situation seems even worse in different ways. Not only the number is a problem, but also the level of preparation of the caregivers to take care of infected or suspected patients, to prevent the spread of the virus and to protect themselves from contamination. Doctors and nurses have been facing different risks, such as exposure to the risk of contamination, physical exhaustion, burnout, adaptation to the rigid work organization, management of shortage in material, the unusually high number of deaths among patients, colleagues, and relatives, ethical issue even, we saw that in Italy and different countries relating to decision-making in a strained healthcare system. Of course, all that gave a certain context, in a context of emergency and uncertainty, and sometimes, and usually, the lack of resources. It's necessary to adopt a strategy capable of fully understanding the risk and minimizing collateral damage. In fact, the risk of contamination of frontline caregivers is very high. As I said, the World Health Organization mentioned a rate of 14% of infected caregivers worldwide. So it is essential to ensure that caregivers are well equipped and armed to care of patients with COVID-19. Therefore, many caregivers have changed their practice. People, nurses went to work in intensive care units, for example. So they were working in different departments. This has led to a critical just-in-time education and training using new technologies such as virtual simulation, intensive e-learning. In context of testing and integrating new process and rapid changes to practice, the learning system is occurring at unprecedented volume and speed. Establishing a clear process to collect and report learning outcomes has been essential for staff and patient safety to reduce preventable harm. I will give our example here in Tunisia. We have developed quite in April, in a couple of weeks, a free online training platform dedicated to caregivers in charge of COVID-19 patients. The training process took place in several forms: educational videos with slides, educational video using also high and low fidelity medical simulation, and 2D educational videos. All training were offered with a prior and post-training assessment in order to evaluate skills development level. The platform offered for the first time a high fidelity live streaming simulation session with a needle tool to tackle management issue of critical simulation in controlled environment and without risk for patient and professionals. Of course, the lockdown was important for us to develop such a new technology and important to bring the right answers to these people in face of danger. Of course, we need to learn from this experience. The shortage is not a fatality. The shortage of health work forces, it's not a fatality. We need to work together, use new technology to improve our this problem, to improve our way to tackle this problem. It's important to increase. It's not only about quantity, as we saw in the COVID, to face the COVID. It's about quantity, quality, and relevance. For example, in Africa, there is some unemployed healthcare worker because they're not trained in the right domain or sector. So for me, it's really important. I think there is definitely, as said, Kate, the private sector need to work a better role and need to collaborate with the public sector, and they need to work together, because the availability of the healthcare workforce is an issue, and we cannot afford quality healthcare for our African citizens without the quality of healthcare workforce. So thank you again for giving me this opportunity to talk about very important problem, and hopefully in the next future it won't be any more a problem but an opportunity for teenagers in Africa.
Thank you so much, Dr. Dagud. Yeah, I think your work in simulation is especially important because although every patient wants access to healthcare workers, many object to being seen by health worker students. And that's a huge challenge. Simulation can get around some of that. And also simulation can get around some of the shortage of healthcare worker instructors as well. So while we're waiting for the next question, I think, which will pop up shortly, I'll introduce our next panelist. Here's our next question. So the question is, what prompted you to attend this webinar? So click on the radial dial of your choice, and we'll see the answers at the end of the session. So our next speaker is Marjorie Mulligan, who's the Senior Program Lead at Mothers to Mothers. So Marjorie holds an MSc in Applied Human Nutrition and is Mothers to Mothers Senior Program Lead, where she supports technical design, program integrity, and innovation. Marjorie has 14 years of experience in design, management, quality assurance, and quality improvement for integrated programs in the areas of maternal and child health, nutrition, HIV/AIDS, chronic illness, water and sanitation, hygiene, and household economic strengthening. She's now working to tailor programs to the global COVID-19 pandemic. Marjorie will be speaking on the role that community health workers play in creating a responsive and resilient health workforce. Marjorie.
Thank you, Kate. And thank you everyone who is listening to me. I hope you can hear me clearly. Yeah, today I will try to speak about and to contribute or share thoughts around the role and contribution of community health workers as part of a responsive and resilient health workforce. And I actually, I read through what AHB has done so far, the webinars that have happened around a resilient health system. And I was quite excited that this panel session on HRH comes in at a very timely manner because pulling together a resilient human resource for health requires adequate healthcare financing, which already was talked about, adequate resourcing through making sure they have an efficient supply chain that allows them to get equipment and supplies and other logistics, hence creating an enabling environment for them. Also managing the disease burden through robust comprehensive prevention and pre-screening for disease using community and household interventions. And that is where community health workers start to come in and lead on. This prevention and pre-screening of disease at community level also creates an algorithm that supports presumptive and high-risk clients to be referred for diagnosis, care, and treatment, while the low risk remain in community under the care and support of the community health workers. And in this way, decanting of the health systems happens, and rationalization and reduction in workload of our clinical or professional health workers actually is increasingly rationalized. Today, we are all here to share our learnings and experiences in developing, maintaining, and retaining a skilled, well-motivated human resource for health that delivers quality of care at all time. At the same time, I was also looking at creating effective bidirectional linkages and referral systems within a decentralized health system that is facilitated by a decentralized health workforce by facility type, which allows for decongestion of some popular health facilities. The lowest yet most critical HRH-led service deliveries at community level by a cadre of community health workers who take up very different names across Africa: village health teams, community health volunteers, and so on and so forth. But with the right tools and messages, these CHWs are able to refer, link clients to appropriate levels of health facilities, and with advocacy may actually be able to help our clients seek services first from the basic care units, which is one of the challenges of our professional health workforce face, because everybody wants to go and seek care in the referral health system. So how do these community health workers support to improve confidence that these families can actually go to the nearest level 2 or level 3 healthcare unit and also get the basic services, with an understanding that there are services that definitely will be referred to the national or regional referral hospitals. So this would actually strengthen decentralized health systems management. Also, I would like to share something that we all know, that WHO has now a global strategy on human resources for health that aims at rapidly recruiting and training and deploying 2 million community health workers in Africa. And this draws on a vast body of evidence and substantial regional experience that community health workers save lives and also improve quality of life, and how investments in these often called lay cadre effectively harnesses the demographic dividend, reduces gender inequality, and accelerates economic growth and development, as one of the panelists said. Indeed, the benefits of community health workers stretch from one end of the agenda for sustainable development to the other. Now, with this in mind, my responses to these key strategic questions, I think I'll speak to HRH strategies to meet the challenges of COVID-19 and future health needs, and probably, if I have time, the role of the private sector. But we all have said and have learned that COVID-19 has placed significant strain on the health system and human resources for health at large. And with the health financing, equipment, and supplies needed to contain COVID-19 and ultimately prevent community transmission, the health system has found itself with no choice but kick primary health care, chronic disease management outside the window, with the limited HRH redirected to COVID-19 management. So the identification and deployment of CHWs to increase demand and provide primary healthcare interventions in the community will be an important step for the future health system to enable the struggle to achieve universal health coverage as we continue managing COVID-19 in these COVID-19 times. A challenge remains, though, that while CHW programs worldwide have taken a variety of approaches to payments, and there are differences based on budgets, and some people even having CHWs called volunteers, the lack of remuneration has been an often stated cause of poor quality of services And so one thing to consider or to discuss is how do we ensure that the CHW provides one's time wholeheartedly and is determined amidst all other issues? And how do we then benchmark the remuneration of these CHWs based on either national minimum wage, but also this should be included in government work plans, and there should be commitment to execution. Lastly, I think I'll talk about enhancing the role of the private sector in building the health workforce. As government health budgets continue to dwindle, and in fact, they're dwindling even more with the COVID-19 fight, building strategic partnerships with private sector in building and supporting the community health workforce becomes more critical. Partnerships may include, for example, with pharmaceuticals for point of care machines to aid diagnostics in the community, mobile community outreach spaces, including gazebos, transportation, manufacturing of PPE, but also we should be also looking at how private sector, especially the telecom companies, can support us to promote telemedicine and telecommunication and virtual social and behavior change communication messaging using products like WhatsApp or Ioba and others that can easily be interoperable with the government systems. I'll stop there for now.
Great, thanks so much, Marjorie. You said so many fascinating things. I strongly believe that community health workers are the foundation of any health workforce team in a country, but we need to distinguish, as you said, between community health workers who are paid a living wage and community health volunteers that, given the fact they're volunteers, a limited number of hours a week are expected from them. And we're starting to see a very creative creation of new types of community health workers, such as health coaches or health accompaniers, so people who accompany complex patients on their appointments, health navigators. There's a lot of evidence worldwide, both in high income countries as well as low and middle income countries, that community health workers improve health, improve patient satisfaction, and improve costs. So really a lot of evidence that they're good solutions. And we're seeing more community health workers being used in the private sector, groups such as Living Goods or Healthy Entrepreneurs, which has developed an entrepreneurial way to make sustainable community health workers at the village level. I also really like what you said about the importance of telecommunications for telemedicine. The fact that there are many villages that don't have access to either to internet or cell phone service at all. It's also affecting currently in COVID health worker education. For example, right now there are over 100 nursing schools in Uganda that are closed because they don't have the resources to get their education online. And so we need to work with groups like Loon, which is Google's initiative, or GIGA, which is UNICEF's initiative, to make sure all health worker schools have access to the internet. It's a very, very important point. So thank you so much. And so we'll wait and see if another question will pop up. Here it is. So the question is, on a scale of 1 to 10, how likely are you to recommend our webinar to a friend or colleague? So click on the radial dial of your choice and we'll get the answers at the end. So our next speaker is Paula Dunn, President and CEO of IntraHealth International. So Paula has dedicated over 25 years to building teams and partnerships that lead to meaningful, measurable progress towards health and development goals around the world. She has almost 20 years of experience with the U.S. Agency for International Development in Cambodia, Haiti, Jordan, Mozambique, Nigeria, and Washington, D.C., most recently serving as a global director of HIV/AIDS. In this role, she led the agency's efforts to help countries achieve and sustain epidemic control of HIV/AIDS under PEPFAR, the President's Emergency Plan for AIDS Relief. This included overseeing a $2.5 billion annual budget, leading a team of 160 staff, and providing guidance and direction to 50 USAID missions worldwide. Dunford's experience at USAID also includes serving as mission director for Cambodia, Southern Syria Assistance Coordinator, the USAID Jordan Deputy Director for Syria-related programs, and the Deputy Director of the USAID mission in Mozambique. Dunford has managed large, diverse portfolios targeting HIV/AIDS, tuberculosis, malaria, maternal and child health, reproductive health, and nutrition. She helped launch PEPFAR in Haiti and led the rapid scale-up of PEPFAR in Nigeria and Mozambique. She oversaw the development of the Global Health Initiative strategy in Mozambique, including the President's Malaria Initiative and the Feed the Future Initiative. Before joining USAID, Dunford served as the country director of the Near East Foundation in Morocco and was a Peace Corps volunteer in Cote d'Ivoire. A native in New York City, Dunford holds a master's degree in public health from Tulane University and a bachelor's degree in history from Northwestern University. Please, Polly.
Hi, everyone. Good morning, good afternoon, good evening, wherever you are. It's an absolute pleasure to be here. And I've been so impressed and inspired by the keynote speaker and all of the panelists so far. It's so important for us to be talking about this today because, as we all know, right now, more than any time in history, health workers are in the global spotlight. At InterHealth, we've been focusing on the health workforce for 40 years. And during these decades, they've been on the front lines of HIV, Ebola, and other infectious disease outbreaks. And as we've been discussing earlier today, when COVID hit, health workers were once again in a crucial and dangerous situation. They needed to address COVID, keep themselves safe, maintain all the routine essential services that people need every day, all of this at the same time. And one way that we found to do this is through data. In Kenya and Mali, for example, we're customizing the WHO surge planning tools to help ministries of health predict COVID hotspots with a high level of accuracy and make sure that they have the health workers ready and available when they need them and where they need them the most. And now we're using these same tools to help governments tailor their pandemic response quickly and remotely. This includes making rapid changes to the tool as the rate of spread changes so that we can estimate the impact on the health workforce as health workers also become infected, unfortunately, with the virus. And the health landscape, we know, needs to grow, expand, and scale, and we need to ensure and maintain quality. We need the strong systems, strong management, and stellar health worker performance of the private sector. So yes, we need greater investment, but really, as we've been discussing later today, better collaboration between the public and private sectors. For example, with the WHO surge planning tools that we've been using in many countries and have been used across the world, we need to ensure, as Kate and others were mentioning earlier, that we're not just planning for the public sector health workforce, but we're ensuring a comprehensive and global look at healthcare workers, private and public, to ensure that as a country or as a region, that we can position healthcare workers where we need them, regardless of public or private sector. We need to bring all of our tools to bear for a very comprehensive and holistic response. There's been a lot of discussion today from Kate, Marjorie, Frank, Dr. Agassi, in terms of education and training and the importance of this in the future of healthcare. It's one area where we've just been discussing that we can do better. So for example, in Mali, in the Gao Nursing School, which is in the very rural north area of northern Mali, which has a very high shortage of healthcare workers. The nursing school now is responsible for graduating 89% of all of the healthcare workers in northern Mali. So we've been partnering with the Mali's Ministry of Health to support this school ever since it opened in 2001. So we're providing local scholarships to local students, which makes them more likely to stay in their communities after they graduate. So today, 93% of the Gao Nursing School graduates have remained in northern Mali, an area that really, really needs them. And I've seen in the chat, and also Dr. Tolenko mentioned the Kenya Afya Elimu Fund. This is a fantastic example of the public-private partnership that works at the decentralized county level, which can be faster and more effective than working at the national level. It's a revolving fund that offers low-interest student loans at 4%, which is rather than the usual 14% commercial rates, which can help Kenyan students get medical training. Afya Lima was a partnership between InterHealth's USAID-funded Human Resources for Health Kenya mechanism, the Kenya's Ministry of Education through the Higher Education Loans Board, the Ministry of Health, and importantly, the private sector. Since 2017, this fund has mobilized over $16 million and has benefited over 22,000 beneficiaries, more than half of whom are women. Another very important point. Solutions like this work. They build economies and bolster the health workforce, but they need greater investment. And another thing that we've talked a bit about today, which I think is very important and want to highlight today, is the importance of mentorship. What if we pair student health workers with private sector mentors while they're still in training, so that we can seed from the very beginning of the health worker career that they can work in the public sector, private sector, and these private sector approaches, which are important no matter if we're working in the public or private sector. And of course, we know that capacity development is not just education and training. It takes systemic approaches to develop individuals and institutions in the local context. We're working to accelerate support to advanced local partners through our program ASAP. We've seen how stronger management and financial capabilities can transform institutions, and how supportive supervision and mentoring with strong HR management systems and the development of career pathways can transform individuals' careers. And at InterHealth, and many of us, in addition to solving the pressing needs of today, we need to look towards the future. So we can't assume that the health workforce problems of today will be the same as the problems of tomorrow. Today's solutions may no longer be relevant in the future. So we've launched an initiative to research, explore, and sketch out a plausible set of futures for the health workforce in sub-Saharan Africa in 2040. The aim was to help the field plan in anticipation of change rather than at the mercy of it. The scenarios we developed, along with today's exciting new rise in self-health care, telehealth, and health literacy, introduce great opportunities for the public and private sectors to collaborate in shaping, reinforcing, and protecting the health workforce in the future. So thank you for everyone for allowing me to enter into this exciting discussion, and I look forward to the rest of our discussion today. Thank you.
Great, thank you so much, Paula. You said so many important things. I think with GAO, it's important for the audience to know that GAO is private. It's a private school, and it's training local students. The model that a lot of countries have is all the health professional schools are clustered in the capital city, whereas the greatest healthcare needs are in the rural areas. I think people need to understand that in some ways, these are entirely different labor markets. You cannot get a young nurse from the capital to move to a rural area, especially a conflict affected rural area. You have to train those people locally. That's why GAO has been so successful. It's interesting you see in the COVID response that people have realized you can move medications around, you can move ventilators around. It's much more difficult to move health workers around, either on a short-term basis or on a long-term basis. Polly, I love what you said about mentorship. That's the human element of health workforce training, and we really need to help people plan their careers. Most health workers in their training have no content over where you might work or what you might do, because there's this assumption that you'll work in the public sector. And we need to add that career planning element. And by creating the career pathways, we motivate health workers to perform better, motivate their level of effort, and increase retention. So completely agree with all of that. So our final speaker now is Nawera Nigeru, and she's the Global Health Director, Eastern Europe, Middle East, and Africa for BD. So Nawera is the healthcare executive and technical and commercial experience gained from the pharmaceutical, medical technology, and diagnostics industry. She has led engagements, partnerships, and programs on patient safety, healthcare worker safety, access to HIV and TB diagnostics, and antimicrobial resistance. She's passionate about women's health, gender parity, and is a champion for the development and advancement of female leaders in healthcare. Nyawera will speak on health worker safety. Please, Nyawera.
Thank you, Kate, and thank you, Africa Health Business, for inviting me to speak on this very important subject. The risk of being the last person to speak in such a powerful panel is to agree with everything that the panelists have said. But I think for me today, the real challenge is not to agree with what I have heard. There's been a lot of reflections and discussions around what we have learned out of the COVID experience and how we can tweak or turn around our education and training to continue to support and improve the skills of healthcare workers that we need for today and for the future. Dr. Elizabeth Walla had a very interesting question in her start, and she asked, how can we care for those who care for us, and how can we prioritize the safety of healthcare workers? So a lot has already been discussed around training and education, and so I want to bring in the additional lens on the subject and just speak a little bit about healthcare worker safety. And this is becoming very important now as we are seeing more and more patients who are requiring critical care. And as we await in anticipation for the vaccine, healthcare worker safety begins to come to the fore once again. The reason being that mass immunization and the heavy workload that we are currently seeing is a major contributor to potential risks and potential exposure to blood-borne pathogens. So I hope through this conversation, we shall be able to have some solutions on how we integrate healthcare worker safety as part of training, education, and development of the healthcare workforce. Healthcare safety, honestly, is not a new subject, and this is only being amplified now by the COVID pandemic. And we all know that a safe work environment, which includes the availability of the right tools, is important to protect our existing workforce, but also to attract more people to join. Let me share my own personal story with you just to begin to put some of these things into perspective. And the scene that I want to take us to is in the late 90s while I was working in the clinical practice. And on this particular night, I am on the night shift, and we receive a patient who has had a head injury post a road traffic accident. Now, to determine the extent of the injury on the head and prepare this patient for more investigations, we have to remove the hair that was on the head. This was a female patient who had hair that was stitched on. And so I take a scalpel or blade, if you like, which is what
Okay, I think we may have temporarily lost Nyawera, so hopefully she will be able to rejoin us. So in the meantime, while we're waiting for her to rejoin us, we'll start with some questions for the panelists. So several people sent in questions ahead of time, so I'll start with those. So the first is from Simi from USAID Liberia, and Simi asks, how can we leverage the private sector for improved health outcomes? So of course, using a health workforce lens, how can we leverage the private sector? So if any of our panelists would like to address this question.
Kate, I can take that. This is Elizabeth.
Thank you.
Okay, and I will take it on the lens of my role as the Vice Chair of Kenya Healthcare Federation, maybe giving an example of what we did in Kenya. So the private sector rallied up into a task force that became a COVID-19 emergency response committee. And in our Human Resources for Health committee, what we did is we quickly identified through our membership the kind of human resources for health gaps they had. And this was not just in numbers, but also their skill set. We also put together some trainers of trainers in partnership with the Ministry of Health. And these were equipped with the skills necessary to cascade that kind of training to their health, their different respective facilities. Because what we observed is that a lot of this focus for the pandemic was very heavy on the public sector, and often the private sector is forgotten. But we also rallied our private sector members, not just in health sector, but also in the wider private sector companies to donate PPEs, to donate goodies. We had flowers, hope for flowers that were sent to health workers just to encourage them. And then some of our members are also very heavy on the digital space. And one of the apps that the ministry is using was invented by one of our members, which is for home-based care and also for identification of symptoms, especially for travelers. We supported, through our networks, we supported a lot of health advocacy for the health workforce. This is through the government to rally more support towards recruitment and reimbursement of the same. And we are in advanced stages discussing about how do we compensate our health workers who get infected, how do we compensate the families, insurance covers, and that like. So thank you very much.
Thank you so much, Dr. Elizabeth. And I just want to make one comment on that, is I think we need to take a look at the regulation of the private sector, because what we see in many countries is we see completely different standards required of the public sector and the private sector. Often we see the public sector getting a pass and the private sector being hit with standards that really are unattainable in that country, given the realities in the country. And I see that extending across the entire life cycle of the health worker, from the education of health workers to the actual practice of health workers. So I have good news in that Nawira is back. So Nawira, please start where you left off.
Hi, Katie. Just to check, can you hear me?
Yes, we can.
Oh, so I'm not even sure where I dropped off. Really sorry. This is part of technology, and that goes to say that technology always doesn't go our way. So I'm not too sure where I did drop off, but what I wanted to say is I want to pick up the subject from where Elizabeth started, talking about how can we care for those who care for us, and how do we prioritize safety of our healthcare workers. And really, healthcare worker safety is not new, but has been amplified by the COVID-19 pandemic. And a safe work environment, which truly includes availability of the right tools, is important for us if we want to protect our existing workforce, but also to attract more to join the workforce. I was sharing my own personal story and experience as far as healthcare worker safety is concerned. And this dates back to the 90s when I worked within the clinical space. And I did have an experience where I did get an injury on my left index finger, which I sustained while using a scalpel at that point. And in the 90s, HIV and hepatitis B were not much talked about. And being infected with HIV was really like a death sentence. And the only thing I took home with me was words from my colleagues on duty with me saying not to worry, that God does take care of us who serve humanity. And I must say that indeed that is true. But if I fast forward that story to 48 hours later, when I was back to the department, I learned that the patient had tested positive for HIV. So there are many similar stories out there. Some of them have been told and a lot of them are untold. And some may be dead and buried, and others did not end the same way as mine did. And that is why I remain very passionate about advocating for healthcare worker safety, even as we think about advancing, developing, and training our healthcare workers. And what we are hearing today from the COVID pandemic is similar probably to what we had during the Ebola crisis, that we have our healthcare workers on the front line and putting their lives at risk just to ensure that they deliver the much required service. A quick reflection was on some data that Kenya published dating back into 2016 on the prevalence of needle stick injuries. This may not be closely related to COVID. However, when I looked at that data, we actually were able to see that out of the 1,700 incidents that were reported, the cadre of workers that were affected included our physicians, as well as auxiliary and support staff within the facilities where the study took place. So this serves to remind us that it is real. Healthcare worker safety is an issue that we must begin to address, but much more to also remember, we are talking about education and training, which costs quite a bit of money that we have to invest into getting all these different personnel well skilled and trained. And the loss of any one of them is really multiplied and amplified because it does affect the service delivery in these hospitals. So as a company, BD has been at the forefront of advancing healthcare worker education and training through our various partnerships and collaborations. Polly did talk a bit about collaborations, as well as Marjorie talking about partnerships. So dating back to 2009, BD and PEPFAR, recognizing that accurate diagnostics is central to good patient management, we launched the Labs for Life partnership, and I think this will go down in history as the longest standing public-private partnership. And here, what we wanted to do was to teach and educate lab personnel on good lab practice and safe phlebotomy to improve HIV diagnostics and treatment at that particular point in time. But you still see how relevant this is today, because when we talk about diagnostics, it is one of the things that we are currently talking about if we are to really tame COVID-19 crisis. We have been in several countries, including Kenya and Haiti, and the methodology that we have employed in this Labs for Life partnership is something that I had Polly talk about, which is a mentorship approach. So here, what we have been doing in these labs is to deploy BD subject matter experts who come and work in these labs as mentors. They support the teams in the labs and help do capacity building, education and training, focusing on good laboratory practice, also helping them move towards gaining accreditation of their laboratories. Because at the end of the day, an accurate diagnosis really does determine how the patient will finally be managed. So this type of knowledge transfer modality has gone to ensure sustainability and complete country ownership of this program. And we continue to see many more healthcare workers benefiting through this mentorship approach. As well, under this partnership, we have established centers of excellence. And in Kenya, which has benefited pretty much, we do have a center of excellence established under the Kenya Medical Training College, which continues to train lab personnel. And on an average, we have 250 students trained each year that is in service training, and continue also to support post-service training as well. This curriculum that we have been using for KMTC and part of our mentorship is now going to be moving onto a digital platform in collaboration with AMREF Health Africa, so that we can actually begin to increase access to many more healthcare workers and many more countries across Africa. We are also expanding phlebotomy to move into infusion safety, because from the data that Kenya did share, one of the other major risk areas they found was in the administration of intravenous medication. And in this space, we did find that most of the doctors actually and nurses were actually the ones that were impacted while administering in IV therapy. So we are working in 9 facilities across 9 counties in Kenya, putting together a whole training curriculum, education, to teach them on infection prevention and control. And this will also go onto the digital platform that we are putting together with AMREF to ensure that many more people do benefit from that education. If I reflect a little back several years ago when we were talking about the expanded program on immunization, BD did partner widely with Gavi, WHO, and UNICEF to ensure that we are actually able to deliver safe immunization programs across all the LMICs where we have been working. And this is also going to become very critical as we are awaiting the arrival of the COVID-19 vaccine. And BD will also be there to partner with countries and other key stakeholders so that we may be able to continue the discussion on safety, as well as deploy our safety technologies and give the appropriate education and training that will be required to ensure safety of both the patient as well as of the healthcare worker. So just reflecting back, I see 4 things that can truly make a difference in the healthcare workforce in Africa. The first I've talked a lot about, which is public-private partnerships. And here, private sector can bring its expertise. We can bring our competence and capabilities, as well as resources that can support education and training of healthcare workers. Philanthropy is a good starting point, but I think building much more resilient models, which can be brought up to scale and can be made sustainable, is what we should be looking at. And the mentorship approach that Polly talked about, I truly do like that. And it's something that we as BD have been working on and will continue to expand. A conducive work and safe environment, in my view, is imperative if we want to talk about attracting and retaining the healthcare workforce. We have a shortage and we need to bring in more to come and join the healthcare workforce. We need to make it attractive by making it safe for other people that want to join, so that they are aware they will not be putting their lives on the line, but rather that they will be coming to serve patients who deserve their time. So here we need to begin focusing on how we retain our current service, as well as how we do attract new people. And we need to be looking at it from the perspective of space design, that is providing rest areas for resting. Dr. Walla did talk about psychological support and mental health. This also must also be provided so that we can ensure complete wellness of our healthcare workers. We must go beyond our current post-exposure prophylaxis, which is what I'll say is a starting point. I look at PEP much more as buying insurance after the fact. I would say let us start to put in the safety belts before we start talking about the insurance that we would be talking about here. And then when we talk about how do we make this all possible, of course, policy becomes such a major piece here. And we're talking about funding so that we are also able to provide adequate and safe tools and equipment for the healthcare workers to protect themselves and also enable them to do their day-to-day work. From the time of the Ebola pandemic and even now, we continue to say and hear that our healthcare workers are at the front lines of this battle. I think we should be thinking more deeply about how to protect our foot soldiers, and maybe here there is something we could learn a lot from the military. I like to say that a good general does not send his troops out to war without the necessary artillery and the gear, unless, of course, the goal is to get them eliminated. So it is a critical piece that we need to be thinking about the policy to support this and the funding that will be required for the procurement of not only the technologies, but also to support education and training. Advocacy is a major piece, and I'm glad that we do have a lot of advocates here for healthcare worker safety, without which we will not be able to move the needle. In the just concluded UN General Assembly, DEVEX in partnership with BD held a sideline event, and here we wanted to draw attention to the issue of healthcare worker safety, and we actually were able to have a presentation and programming called Moving the Needle. So we've partnered on this with DEVEX, and we continue to advocate for healthcare worker safety, and I can share the link in terms of where you can be able to find that hearing. And then finally, what I want to talk about is that if we think about most healthcare workers, and actually it's about 70% or more, they're basically women, as stated by WHO. And so this is not just a health issue, but also a gender issue. So if we want to achieve gender parity, we need to be able to retain women within the healthcare workforce. We need to be able to attract more women to join the healthcare workforce as well. So making it attractive so that we can have more people coming into the workforce. It's therefore necessary, as we think about training and education and how we develop this workforce of tomorrow, that we strive, and as we strive to meet the rising demand, that we also look at creating this safe and conducive work environment where we can protect and retain our healthcare givers. Let me stop there, Kate, and I can respond to any questions that may be on the floor.
Great. Thank you so much, Nalwera. I really appreciate it. I love what you said, that philanthropy is a good starting point, but we need sustainability. I mean, absolutely. And I think an important role for donors is to address the market failures that we have. Because otherwise the private sector can take care of a lot of things. The market will sort things out, but there's some market failures that need to be addressed. And it's fantastic to hear that BD is planning on scaling up its training programs by putting them online, and hopefully a lot of other organizations will do that as well, because I see that as absolutely vital. So now we will go back to our question and answer period. So the next question that we have is on health workforce data. Basically the idea that many governments have good data on the public sector, but they have almost no data on the private sector. So this question is open to any of our panelists. How do you see addressing the issue of data of the private sector? And while folks are thinking about that, I like to say that the government has the public sector data, but they also do have the private sector data. They don't realize it because all of the regulators, the nursing regulator, the medical regulator, they have the data on the private practitioners that are in country. So the government needs to start reaching out to them, getting their data and putting it into the National Health Worker Database. Because in the past, governments really just defined the National Health Worker Database as those employed by the Ministry of Health. So we need to move beyond that more narrow definition and have, in fact, WHO has requested all countries to have a National Health Worker Database. And they've set standards for that.
Okay, this is Paula. If I could just jump in, I agree completely. And I think a lot of this is the governance of data, right? And I think then we can foster this collaboration between the public and private and bring it all together. So it really takes that high-level policy work and the governance of the data to frame the infrastructure and the policies that we need in order to bring that all together. So I agree that that is absolutely critical.
All right, and our next question is from James at Sanagest. And he says that there's not enough attention applied to workflows. And so I was wondering if people could comment on that.
Just one point for me concerning the collaboration in terms of data between government about public and private sector. In Tunisia, same thing. We have problem having the right data, and more than that, today as Polly said, we have to have a really high level of data even in the region. Because, for example, in Tunisia, we have a lot of migration towards Europe. So people are leaving, doctors are leaving, and we need to anticipate that so that, I mean, the shortage won't be worse. So I think we have a high level data to need to be integrated, and even more at the regional level, so that no migration will really worsen the situation.
Absolutely. Thank you. And did anyone want to address the workflow question? So, you know, workflows can include time motion studies, job redesign. I mean, I think it's a huge issue. Like if you follow a nurse around, she's often, you know, going back and forth, you know, a lot of time is wasted doing unnecessary procedures that when you examine all of what she does, what is necessary, can it be made more efficient? We find you usually can get a 20% or more efficiency. So James, I agree with you completely on the issue of workflows and also job redesign. Did anyone else comment on that?
Kate, yes, I can add on. I didn't fully understand the workflow, the context of it, but what you address reminds me of a very interesting discussion. I think it's almost 10 years ago. I had it with a big referral hospital in Europe, and they realized the same, that the waste of time within the workforce. And imagine what happened, that it was through a personal friendship. They invited the process workflow designers from Porsche, the car manufacturer. And then they took them into the hospital, and they really came then with a real industry view on how to optimize that. And I think the gains they had at that time was even beyond 30 or 40%. So I also think there we have to be open enough to look outside of the healthcare industry and not always claim it's special and it's different. We have also be open to talk to other people who have really done a good job and have a lot of experience in workflow design.
Great, thank you. I agree completely, absolutely. The next question we have is from Ezekiel, who asks about medical diagnostics and how we can get health workers to, you know, improve their uptake of the proper use of medical diagnostics. We certainly know, as someone mentioned before, a huge issue was making sure that health workers were doing the COVID test properly. So does anyone want to comment on that?
Yeah, maybe I can start with that. I believe with diagnostic, it's similar to pharmaceuticals, it's similar to other technologies. There is a lot of development and there is innovation. And the curriculums and the textbooks are written and designed at one point in time. And I think there we need to have a kind of exchange between innovators and between the training sector to make sure how can we bring in new innovations, new technologies into the educational curriculums so that there's always an up-to-date teaching happening. Yes. And that will then enable, of course, the individual to apply state-of-the-art technology and also state-of-the-art science to the patient when they go out there. That would be maybe my point, but I also invite the other panelists to maybe add from their perspective.
I agree with you completely. I think there's a gap between what people are taught and the actual practice. And I think we need a better dialogue between educators and practitioners in the public and the private service to find out what skills health workers need. And just some examples I can think of off the top of my head, every school needs to have a digital health component. You know, the cell phone is a new stethoscope. We really need to make sure everyone is educated in how to use digital health. Another emerging technology that I think needs to be integrated into every medical school is point of care ultrasound. You know, the portable ultrasounds. Every physician should know how to use one because this gets medical imaging down to the community level. It's really very exciting.
Yeah. So Kate, if I can just make a quick comment on that as well, and I totally do agree with you in terms of how you're looking at it. One of the things you will find that, because for example, we do have a center of excellence with KEMRI in Kenya, where we actually have been able to teach flow cytometry, right? And you have students going through there and learning. The unfortunate thing is that once they leave the learning environment, flow cytometry is not available anywhere in practice, or it is available in a limited way. So we need to look at how to integrate both, that we're teaching and educating on this other end, but but that also from availability and access when they go into the clinical areas, that is also made possible. We need to see how to have that complete end-to-end linkage.
Exactly true. I agree with you. Absolutely. We have another question from John, who asks about task shifting and how countries can do a better job of task sharing or task shifting to make sure everyone has their healthcare needs met. While people are thinking about that, some work we've been doing recently is helping Operation Smile look at task shifting in the surgical team for essential surgery, because there are a billion people alive today that don't have access to essential surgery. And it's interesting, in Africa, actually most countries have mid-level providers, and many have mid-level surgical providers. So from that perspective, I think Africa has started on that pathway, but they certainly have a way to go. Does anyone else want to address that question?
Yes,
I think for,
this is Marjorie.
Please, Marjorie, go first.
Yes, I just would like to say that task shifting and having a graduate intern is quite similar, because most times when we get these interns, we do not necessarily want to dump everything that we do not want to do on them without actually telling them what to do. They're not the ones to photocopy and do that. And similarly, for some of us who work with community health workers and peer mentors in the facility, I think having the professional healthcare workers be their senior mentors and provide them with the skills, rather than thinking that because they've been working in the healthcare system for a while, they are going to have default settings that allow them to do what you're doing. Then most times task shifting may actually negatively impact on the client's outcomes. And for task dumping, that is even worse, which we have seen happening, where health workers actually do not even attend work in some rural areas, believing that the expert clients will dispense, medicines based on, for example, even pediatric medicine sometimes are left to those people they are task shifting to. So there's, I think in the developing world, there's a lot of task shifting to nurses from doctors, but then in most of the African countries, it is really sometimes it defeats the purpose. And we as people who want to grow resilient and responsive health systems need to invest in capacity building and on job mentorship of those people who are given the responsibilities. Thank you.
Okay, does anyone else want to address that question?
Yeah, maybe I can add another perspective on it. I think also on task shifting, for me, belongs the question, where do I go to which type of healthcare service provider? And I just recently had a discussion with a national health insurance fund, and I believe the role of the payer is very important. So I think also a patient who is having a flu shouldn't get a reimbursement if he's accessing a level 4 or 5 hospital to get the treatment of a flu. But we have to make sure then reimbursement only happens when I'm then really at the primary care provider. And then I can also basically shift make sure the patient flow goes to the right level in the healthcare system, and the payer can do a lot about that.
Great, thank you. We have another question from Victoria on how can we increase financing of health worker education. You have mentioned Afia Alimo. I know of Dana Sita, which is a group active in Indonesia and Philippines, which is trying to increase some access of loans to students. Anyone else want to comment? So, and also during Capacity Plus, we generated a report on innovative finance for pre-service education. So that's available online.
I think for me personally, one of the key elements is when we invest in education of healthcare workers, how sure can we be that there's a sustainable employment on the long run? Because I think often it's not so much the difficulty to get money from industry, from NGOs, even from government development funding, whatever you want, we can find resources for training. But we all will ask what happens when they finish their training. Will there be an employment with a decent salary for the people we do? And we just have a cooperation now with Her Excellency, the First Lady of Kenya, to train community healthcare workers in arid regions of Kenya. And the key element of the contract was that there is a commitment from the counties to employ then the community healthcare workers when the training is done.
That's fantastic. So either an employment commitment or actual bonding. Fantastic. Because you're right, there are many unemployed health workers because there's this mismatch between who's trained and what the needs are. So with that, I'll close our question and answer period. It's now time for our parting shots. And this is an opportunity where our panel will have a chance to share take-home messages. And my take-home messages, relates to my opening statements about the public-private partnerships and the fact that, the public sector can't do it alone. We definitely need to look at the regulation across the entire life cycle of the health worker and ensure that regulation is changed so that there's one set of standards, not two, so that private sector can invest in training more health workers and can invest in employing more healthcare workers. So we'll go in the order of which people spoke. Dr. Elizabeth.
Thank you very much. For me, my parting shot is that we've moved from saying frontline health workers to health workers being the core of the system. Thank you.
Okay, so Frank.
Thank you. I would like to call on my peers in the industry to say, don't sell products, sell solutions, and sell an ecosystem approach to your customers. And I call on the customers, don't source for individual products, but really source for solutions. The more integrative they are, the better is the value of what you get. Thank you.
I love that. Don't sell products, sell solutions. So Dr. Ghazi.
Thank you. My real message is really, I call for solidarity between African countries and to tackle this problem. I think there is possibility to work together and really to find out solution because I think it could help for the growth of different companies in different countries in Africa. And if we work together, we're able to find solution. That's very important.
Thank you. Marjorie.
I think what I can say is client-centric. I believe that if we all continue to make sure that the service delivery we provide is client-centric, then this will reduce the burden of the healthcare system or on our healthcare workforce while improving the outcomes, because not everybody needs the same thing. And so we need to give those who need more, and those who need less. Thank you.
Thank you. Polly.
Thanks. I guess my hope for all of us today is that right now we can step beyond this panel conversation to form new and solid partnerships. So I have 3 ideas that I'm going to be focusing on. One is the data piece. We talked about this, the governance. We need to not just have public sector data or some private elements. We need the governance to work so that we're including all aspects of healthcare workers so that we can plan holistically, because the private sector is so important to the healthcare system. So we need to bring that together and plan and coordinate together. 2, health worker training. We talked a lot about it today. Again, we need public and private sector engaged together to ensure that we have the workforce that we need moving forward. And then getting ready for the vaccine drive of the century, which is happening right now. We need to do that together. We need public, we need private. And Frank, I love the way you talk about an ecosystem. It's not a product, but we all have to work together to create this ecosystem so that we can get the product out to the people who need it the most. So thank you. It's been a pleasure to be with all of you today.
Thanks, great. You know, it's interesting, many countries have had successful initiatives with pharmacists giving vaccines. So sort of expanding the types of health professionals that give vaccines. And of course, the important issue you mentioned of the national health workforce accounts. Nyawera.
So my take really is that training and education is really critical. However, we need to couple that with a safe work environment to help us attract, develop, and retain our healthcare workforce. And that's the only way we can also be able to make it meaningful for people to want to join the healthcare workforce. Thank you very much for this very engaging conversation on a very important topic.
Thank you. With that, I'd like to hand it back over to African Health Business.
Thank you so much, Dr. Tolenko, for leading this engaging discussion, and to all the speakers for an informative and interactive session. Thank you so much. A true showcase to our commitment and concern for our health workers, especially during this COVID pandemic. So let me go to our next section in the webinar. We have results to our exciting pop-up questions. And I don't know if you can see the results. Yes. So on the question where we asked, what are the biggest challenges to human resources in Africa's healthcare sector? 28% selected the poor geographical distribution of staff received. Poor geographical distribution of staff. So this really shows that the government and the private sector need to work together to ensure that the populations across each country in rural and urban areas get access to health workers. The second question that we had on there was what factors contribute to improve health service and delivery in Africa? At right under 50%, response leaned on answer number 4, optimizing the utilization, retention, and performance of the active health workforce. This means that we need to focus on managing the workforce in an effective manner. We need to create an enabling work environment that we need to work towards creating an attractive work environment for our health workers. So thank you so much for this participation. These key questions that we asked will lead our discussions in the next round of webinars. And unfortunately, we've come to the end of our discussion. And so on behalf of Africa Health Business, I want to extend a special thank you to all of you, our partners also who made this webinar possible. I would like to highlight that next Thursday at 3:30 p.m. East Africa time, we will be hosting our thematic session on access to COVID-19 vaccine for Africa. And I ask you to register for this exciting and timely session. If you are interested in learning more about Africa Health Business and our services and partnering with us, please feel free to reach out to me using the contacts that will be shared in the next slide. And we are very excited to see you again soon. And thank you so much for joining us this evening for this wonderful, wonderful session. Have a lovely, lovely day, lovely evening, and thank you so much.
Thank you. Take care. Everyone. Goodbye, everyone.
Bye.